Welcome everybody to this research showcase, Allergy at Imperial. My name is Dr. Marta Vazquez-Ortiz. I'm a consultant in pediatric allergy at Imperial NHS in London, and I'm the course director of the Allergy MSc at Imperial College London. And it's my real pleasure to be here today chairing this session where we're going to have our academics presenting the latest developments in the research in allergy and asthma. Next slide, please. So innovation and excellence in research at Imperial goes back many years, as it was here where allergen-specific immunotherapy was first developed by Noonan and Freeman over 100 years ago. Next. And this world-class research, and I will say excellence in clinical practice and education in allergy, has continued over the decades, and we're very lucky to have truly outstanding academics who have devoted their career to allergy and asthma and who will be speaking to us today. I personally feel privileged to work very closely with them in my role as director of the Allergy MSc at Imperial. All of them are module leads in the program and heavily involved with teaching, and it is a very exciting atmosphere to work in and to study in for our students as well. So as I said, we'll be hearing today about the latest developments in the research in allergy and asthma, and I hope very much you enjoy this. Next. So as you know, now in this virtual world, there are no nibbles, no coffee. So I think we're all here for the science, and this is the program we have today. We have 3 sections. The first on food allergy and anaphylaxis, where Dr. Bob Boyle and Dr. Paul Turner will be speaking. Then asthma with Professor Kustovich, Professor Zaglani, and Dr. Lowenthal. And last but not least, we have immunotherapy with Professor Steve Durham and Dr. Mo Samji. So each speaker will have 10 minutes to go briefly through the topics. And then after each of these 3 sections, we will have 5 minutes for Q&A. So please, there is a chat function in this Teams event. Please put any questions in the chat box, and we will try and address as many as we can at the end of that section. So next slide, please. So that's all I wanted to say as a little introduction. I will be introducing the different speakers within each section, and then I will hand over to them, and then we will pick up the Q&A. So we're going to be talking about food allergy first with Dr. Bob Boyle and Paul Turner. And just as a little introduction, so Bob Boyle is a consultant and a reader in pediatric allergy. He's also Associate Professor of Evidence-Based Dermatology at the University of Nottingham, where he's joint coordinating editor of the Cochrane Skin Group, and he's also the joint editor-in-chief of the journal Clinical Experimental Allergy. That will be followed by Dr. Paul Turner talking about anaphylaxis. Paul is a consultant and a reader in pediatric allergy and clinical immunology as well at Imperial, where he's also the director of the Children's Clinical Research Facility. He has a number of roles in a number of national entities, including Public Health England, Food Standards Agency and MHRA, and he's also the chair of the Anaphylaxis Committee in the World Allergy Organization and the chair of BSACI for the Pediatric Allergy Group. So very happy to hand over to Bob for the first talk today. Thank you.
Thanks, Marta. So I'm just going to give a very brief overview of food allergy research at Imperial. Food allergy as an academic enterprise is something that has really boomed in the last 25 years, and we've learned a lot about what food allergy is and the different ways in which it can impact on people's lives during that period. I'm just going to give you a brief snapshot of what's going on at the moment in food allergy research at Imperial in the areas of prevention, diagnosis and management of these conditions. Next slide, please. In terms of primary prevention of food allergy, the biggest discovery in the last few years has been the recognition that oral tolerance to food antigens works in humans as well as other mammals. at least in relation to development of IgE-mediated food allergies. So that earlier introduction of allergenic foods reduces the probability of developing an allergy to those foods. But I don't think the story ends there, because it's very allergen specific, this effect, and you'll see that in the chart there from the LEAP study, where you'll see rates of other allergic conditions, or indeed any food allergy at all, are actually quite similar in infants who've eaten peanut or avoided peanut. So there's remaining questions really about how to use this information and this scientific tool to prevent food allergy from developing, and how to, develop public health intervention programs that work in an achievable way. And that's really underpinned by rigorous evidence synthesis, and we have an ongoing program of work being updated, pulling together the increasing body of evidence around what works, what doesn't work, what types of outcomes are changed by early allergenic food introduction. Next slide, please. And the other sort of very hot area of primary prevention of food allergy at the moment is skin health. And anyone who works with food allergy will be aware that there's a close association between skin health, so dry skin or eczema in the first year of life, and subsequent development of food allergy. But we don't yet know how to turn that into something useful to stop food allergy developing in the first place. So really, we're working a lot around skin care. And it was disappointing last year to find that moisturizers don't seem to be working for preventing eczema or indeed food allergies. But again, the story doesn't end there. Only very specific types of interventions have been tried so far. There are a lot of ongoing trials, and we've got an ongoing individual participant data meta-analysis, which is an ongoing program of work pooling together data as they come through from these trials. So we're really at the forefront of understanding what ways of looking after infant skin care can impact on risk of developing eczema, food allergy, and other allergic conditions. Next slide, please. And then the third area where we're sort of active in relation to prevention of food allergy is really pushing back on some of the myths that have been promulgated in recent decades around things that are thought, presented as preventing allergies, but don't appear to do so. And this is one such myth around hydrolyzed formula, so a special form of infant formula milk, where really unreliable scientific outputs combined with excessive enthusiasm from professionals and scientists, partly related to conflictive funding arrangements, have resulted in inappropriate recommendations around these sorts of interventions over the last 20 to 30 years. Next slide, please. And that falls into a sort of wider concern around excessive enthusiasm for allergy interventions could sometimes spill over into adverse effects on general infant nutrition and public health. Next slide, please. So on to diagnosis. And diagnosis, really, we've got two streams of work, one around IgE-mediated food allergy and one around non-IgE-mediated. The IgE-mediated food allergy diagnostics are pretty average in their performance. So they don't give us a really precise readout as we get in some other health settings. So there's a lot of work to be done in terms of improving diagnostics, making them more acceptable to patients and their carers. And Paul Turner's leading a lot of that work. And the other area around IgE diagnostics is really around prognostics and thinking about what goes, can we distinguish between people with IgE-mediated food allergies who are at risk of dropping dead within minutes of eating the relevant food, and the vast majority of people with IgE-mediated food allergies who appear to have more self-limiting reactions and not be at risk of fatal outcomes. And we've got a clue there, I think, in the at least in the age distribution there and other work. And Paul's managed to get some good funding to try and drill down into what exactly is going on with fatal or near fatal food anaphylaxis events. And in terms of non-IgE mediated food allergy, Marta is leading. I mean, the diagnostics are even more woeful compared to IgE-mediated food allergy. But Marta's leading a very exciting project, BioFPIES, which is a consortium of pediatric allergy centres around Southern Europe and UK, using gene expression methodology to try and develop robust diagnostics for non-IgE-mediated food allergy. Next slide, please. And again, we have a sort of a third area of interest, which is really the sort of commercial exploitation of allergy and leading to sort of inappropriate interventions in infancy. And here we see on the left data from England showing volumes of specialised formula use for managing milk allergy, which are going up and are at around 10 million litres a year. And the red line on that graph is the expected volume if every milk allergic infant was diagnosed immediately and where appropriate, a specialised formula was used. So what we see there's about a 10-fold over use of these products, and so again, there's this feeds into sort of potential harms of overexcitement about allergy, particularly in the context of infant feeding in those first months of life. Next slide, please. And then in terms of management of food allergy, I think we've got a much more holistic approach than many centres. And the reason I say that is that there's two key areas really: priority setting and core outcome set development in the context of food allergy. So again, Paul has just undertaken one of the most comprehensive pieces of priority setting undertaken in food allergy so far. And the key about this is that patients' views and their experiences of living with food allergy and their concerns and uncertainties are right at the centre of the priority setting. And what that means is that he's setting the direction of travel, at least for Food Standards Agency funded work, so that the research questions being asked are questions that are important not just to clinicians and scientists, but particularly to people living with food allergy. And similarly, Daniel Mumblit's leading an EU-funded project called COMFA, which is the first core outcome set development project in food allergy, and again has patients very much at the centre and patients' concerns at the centre in terms of what should you measure. If you've got something exciting that might help make people's lives better with food allergy, and you do a controlled trial with that intervention, what are you going to measure at the end to understand whether it's worked, whether it's really improved people's lives? Now, at the moment, a lot of trials will measure immunological outcomes, thresholds of reactivity, food challenge outcomes. They're probably not really what patients are interested in day to day in their food allergy. So the COMFA project again is another more holistic project around food allergy. And once those two pieces of work are established, then the COMFA outcomes should be measured in most clinical trials of food allergy treatments going forward. And of course, we do have our own trials running and based on some of this work, so food allergy immunotherapy, etc. So that's all I wanted to say really about food allergy research at Imperial. I'm going to hand over to Paul Turner now, who's going to talk a bit more detail about anaphylaxis in particular.
Thanks, Bob, and good afternoon, everyone. So I've got 10 minutes to tell you about the pioneering work we've been doing in food-induced anaphylaxis here at Imperial, and this very much has been a partnership with pretty much everyone you're going to hear from today. Been working very closely with Bob as well as Steve and Mo and Adnan, really trying to bring new techniques to better understanding how we can improve anaphylaxis management and make better the lot that our patients and their families have in caring for children and adults with food allergy. Next slide, please. And so for many of us, our perception of food allergy is very much swayed and founded by headlines. And I'm sure you'll recognise many, if not all, of these pictures that you can see in front of you of people who have had fatal outcomes which may or may not have been due to exposure to a food allergen afterwards. And it's challenging because on the one hand, we really need to try and do everything we can to protect people from these very severe outcomes. But on the other hand, these severe outcomes are actually, fortunately, vanishingly rare. And where we fall down as a community at the moment is that we have no way of identifying people who are more at risk of these tragic outcomes. Who are the people who really need to be exceptionally careful over allergen management, over dietary avoidance, over having rescue medication, having a proper plan so that if something does happen, they can be kept safe, as opposed to the vast majority of people who actually, when they have anaphylaxis, they find they may need 1 or 2 doses of injected adrenaline, but actually they're never at risk of having a truly life-threatening reaction. We don't want to play Russian roulette with our patients. We don't want to play Russian roulette with our children. And that's why we need to better understand anaphylaxis and understand the risk factors that predispose patients to having these very severe reactions. Next slide, please. And so what have we been doing? We've been trying to define the issue. How much of a problem is it? What foods tend to cause more severe reactions? And can we identify who's at risk? And then we're trying to improve things. So in order to better improve management, we also need to understand what goes wrong, because then we can target where we improve and how we improve things. And we need to understand how to decrease the burden. That's both at a patient level, an individual level, but also at a public health policy level and at a global level, as we'll see. Next slide, please. And so some of the work we've been doing over the last 10 years or so is analysing NHS data sets to try and milk this as much as possible for real information that can impact positively on patients. And so one of the things we've been looking at the rates of hospital admissions with anaphylaxis, tracking those, but then matching that to the tragic fatal outcomes that we sometimes have. And I think we have to put out the good news here that even though admissions to hospital with anaphylaxis are increasing, we are getting better at managing deaths. We've got a reduction in our case fatality rate. And you can see here the data for the UK. Next slide, please. But it's improving everywhere. The story within the UK is interesting. Another thing that we have really managed to sort of help and are now sort of banging the drum loudly is the fact that everyone understands that peanut and tree nuts are typical causes of severe reactions and anaphylaxis. But actually, we've demonstrated a massive issue with cow's milk because it's so ubiquitous in our diet. It's quite a concentrated allergen, so you don't need very much of it to have a severe reaction. And it's now the single leading cause of fatal anaphylaxis in children. Next slide, please. So as I mentioned, while the perceived risk is due to peanut, and restaurants and food businesses understand that, actually there's a hidden risk. Next slide, please, which is cow's milk. And we really need to raise the profile so that we change the perception that cow's milk is always a mild allergy that people outgrow, because if you don't outgrow it, you're at more risk of severe reactions. Next slide, please. The trend that I showed you for the UK, we've also identified is occurring globally as well. So you can see here, hospital admissions due to anaphylaxis increasing. Next slide, please. But even in Australia, with very high increasing rates of anaphylaxis and possibly severe anaphylaxis, the case fatality rate is actually stable, and it's falling in the USA, and it's more than halved in the UK over the last 10 to 15 years. Next slide, please. Can I have the next slide, please? Thank you. And we also need to understand which allergens are the problem. So I've already highlighted in the UK, milk is a problem, but we've conducted a systematic review, which is now informing global public policy work to identify which allergens should actually be in the list that food businesses have to declare either globally or at a regional level. And this is some work that's just been published in the Journal of Allergy Clinical Immunology. Next slide, please. Similarly, we're trying to identify who's at risk of proper life-threatening, near-fatal or fatal reactions. And again, by interrogating NHS data sets, we've been able to identify that while most anaphylaxis seems to happen in preschool children, they seem to have some inherent protection that stops them from having near fatal or fatal reactions. And one can see from the red dots, the case fatality rate, that the risk really starts going up in teenagers, but then persists through to people in their mid-30s and even late 30s as well. And we're trying to understand what physiological differences account for this. Next slide, please. Thank you. And the next slide. And so to do that, we need to understand what really happens during anaphylaxis. Next slide, please. And so we did what was previously thought unthinkable. We have taken over 100 adults and children with peanut allergy, and we've repeatedly challenged them with peanut, so they have reactions. Around 20–30% of the time they have anaphylaxis. And we've watched them like a hawk to work out what's happening when people react. What's the body doing? How's the body compensating? And we've shown that irrespective of severity, there's a reduction in the amount of blood that the heart pumps around the body when people have an allergic reaction. And because that amount of blood drops, there's less blood coming back to the heart pumps faster, more quickly in order to maintain circulation. Next slide, please. So we might think that actually, if this is the case, stroke volume is decreasing, that there's less blood coming back to the heart when people have severe reactions, and that's why people collapse. What can we do about it? So the first is, well, actually give them IV fluids. And we've shown that IV fluids has a rapid effect in restoring venous return during allergic reactions, and interestingly, seems to hasten resolution of abdominal symptoms. Data shows that over 1.5 litres of fluid leaks out of the blood volume when people have reactions, and that probably goes into the gut. And so this sort of makes sense from that perspective. Next slide, please. Can I have the next slide, please? Concerningly, we haven't seen much of an impact of a single dose of intramuscular adrenaline epinephrine when that happens on stroke volume. So these data here, which again we only published at the start of this year, has shown that yes, while heart rate does go up when someone gives themselves an epinephrine, an adrenaline injection, there's minimal impact on stroke volume. And actually there's far better outcome on stroke volume from giving intravenous fluids than there is from just a single dose of adrenaline. Next slide, please. So what do we do with this data? The first thing is to know that significant fluid shifts can happen even in mild reactions. The second is to note that there's a limited impact of a single dose of adrenaline against cardiovascular symptoms. And so if someone is having a cardiovascular reaction rather than a respiratory asthma type reaction, they're likely to need more than just a single dose of adrenaline. And recognizing those patients early is key to improving outcomes. Next slide, please. Those data have directly impacted upon the latest anaphylaxis guideline in the UK from the Resuscitation Council UK, as well as a global refractory anaphylaxis guideline, which you can see here has recently been published in Allergy as well, so that we can spot these people early and rescue them appropriately. Next slide, please. And then finally, we're changing the risk profile of food allergic individuals. As Bob mentioned, we're undertaking pioneering oral immunotherapy studies, as well as oral immunotherapy mixing with other adjuvants to try and increase the amount that people need, first of all, to have a reaction, but secondly, shifting their reaction profile so that when they do react, as you can see here on the right hand of the screen, with red and yellow symptoms, after treatment, it's just green symptoms, or even the magical green zeros, where they're simply not reacting anymore. So they're less at risk of reactions. Next slide. And where's this all going? The work that we've been doing has directly impacted upon the latest Codex discussions at the Food and Agriculture Organization of the United Nations and the World Health Organization. And this is going to have global ramifications on improving allergen labeling for allergic consumers and their family. So take part, help us with this research, be one of our researchers, and let us continue improving things for food allergic consumers. Thank you.
Thanks so much, Paul and Bob, for these excellent presentations. It's time for the Q&A. We have about 5 minutes, and we got at least 3 questions for now from the audience. The first question is, I think, Paul, you will be very well placed to answer that. So someone was asking about why in the age group of 10 to 20 years old you see a relatively high or higher number of food-induced anaphylaxis. Would you like to comment on that?
So I'm just trying to see the question again. Is that the last one at 222?
Is the one before? So, the specific question is, any idea why high number of food anaphylaxis cases reported for the age group 10 to 20? It was about one of Bob's slides, but, because you've led on those studies, I thought you might want to answer.
So we know that in terms of, I'm trying to understand, but it says the age group of 10 to 20. Why is it that there's more hospital admissions with anaphylaxis to that age group? I think naturally people are concerned in that age group with respect to the management of reactions. There's lots of risk-taking behaviours that begin to creep in that age group as well, and therefore that coincides with a time when people are getting at independence. They're no longer having their food intake controlled as much by their parents. They go to other people's houses independently, and that all increases the potential exposure to allergens. Is there an increase in severe reactions, which is what we've identified in the UK database? That's what we're trying to work out at the moment. And so watch this spot. I'd love to give this talk again in 5 years' time, and both Bob and I can give you the answer.
Great, thanks a lot, Paul. That question goes for Bob. So someone is saying that they have a nephew, a relative with pine nut allergy with life-threatening reactions, and they were wondering if there is more focus, or there is a plan to having more focus on other allergens like pine nut. Would you like to comment on that, Bob?
Yeah, and this is one of the difficulties with food allergy, that it's very individual, very diverse. Take 100 people with milk allergy, they'll be responding to different T-cell epitopes. So it's made food allergy, it makes it exciting, challenging as a research area. And yeah, you're right, you've picked up one form of food allergy that can be very severe, impacts significantly on people's lives, but is understudied. So yeah, I don't think I've got much more to say than that, but it's, we can't really go into too much detail in this short call, but the diversity of food allergy is a real challenge for research in this area.
Great, thank you. Next question is a mum, an allergy mum, asking about what I think is probably component response diagnostics. So asking about specific blood tests he's heard about that might help predict severity of reactions. So would you like to comment on that, Bob, as well?
Yeah. Yeah, thank you. So that really cuts to the heart of what Paul's trying to understand. I think in relation to severity, people talk about severity of food allergy in different ways and try and measure it in different ways. But the only sort of severe reaction that you cannot argue that it was severe is when someone dies or very nearly dies. And in the NHS, we're able to identify those people better than some other places, and for those who've survived near fatal reactions, to invite them to be assessed. And I think we really need to understand that before we can make progress with food allergy, because as Paul highlighted so nicely, you've got this terrible balance between these rare catastrophic events which colour all conversations about food allergy in different settings, and then the restrictions. And the restrictions which are partly driven by anxiety about fatalities, but the restrictions which day to day are the main burden for most people with food allergy. So it's a very difficult balancing act, and I think the holy grail of food allergy research really is to fully understand what goes wrong when reactions spin out of control, how to identify when that's likely to happen, and of course how to prevent it from happening. At the moment, none of our diagnostics do that in any sort of reliable way. So if you're being sold that, then that's not a reliable story really. We've got a clue there. I think we've talked a little bit about some of the clues there and what they might mean.
Great, thanks so much for addressing all these questions. We have a couple more that we will address at a later stage via chat. And thanks so much for your talks, Bob and Paul. We're going to move on to asthma now. And we have three really outstanding speakers. We have Professor Kustovic, Professor Seglani, and Dr. Lola Lowenthal. So that's, welcome to the little asthma section here. We have Professor Adnan Kustovic talking about learning from birth cohorts, big data. I will do the introduction of all three of them, and then I will hand over to them. So Adnan is a professor of pediatric allergy at Imperial College London, and as many of you will know, he's done outstanding contribution through his research to our understanding of asthma over the last decades. This has led to a number of national and international awards, including the ERS Gold Medal in Asthma and the BSACI William Franklin Medal for outstanding contributions to clinical allergy. And also in 2020, he was elected to the fellowship of the UK Academy of Medical Sciences. He has prominent roles in a number of journals, including Lancet, Child and Adolescent Health, as well as in societies such as BSACI and EACI. So then we will have Professor Sechal Seglani talking about phenotypes and endotypes of preschool wheezing and severe asthma in children. Sechal is a professor of pediatric respiratory medicine and a honorary consultant in pediatric respiratory medicine at the Royal Brompton Hospital. She leads the section of inflammation repair and development at NHLI that all of us belong to, and she has been awarded a number of prestigious research fellowships and international awards throughout her absolutely brilliant career, including from the European Respiratory Society as well. And last but not least, Dr. Lola Lowenthal is a specialist registrar in respiratory medicine, and she's doing her PhD as a clinical research fellow in Professor Claire Yoitz's group at NHLI, and she will be talking about adult asthma. So thanks so much for joining today, and I'm handing over to Adnan for the first talk. Thank you.
Thanks very much, Martha. Thanks for organizing this. I'm going to be talking about something completely different, something that, biomedical scientists do not necessarily think a lot about, which is dry laboratory. What is dry laboratory? It's a laboratory where computational and applied mathematical analysis are done on a computer-generated model to simulate a phenomenon, in this case, a disease, in real world. Next slide, please. So from our point of view, both from asthma and other allergic diseases, real key is to get from blunderbuss medicine, which is one size fits all, which is what we are doing now, to personalized medicine. And this journey really needs to go through several mechanisms. First one is understanding the underlying mechanism of a disease, i.e. identifying endotype of a disease, then discovering biomarker of the disease, and finally moving towards mechanism-based treatments. And you will see the thread of it through all of the presentations that we currently putting together. And the key to unlocking the era of precision medicine is to understand the mechanism underpinning disease heterogeneity. The consequence of what we're currently doing is we're putting patients with different disease subtypes into single group and then apply empirical treatment. And you've heard Paul and Bob, and the same applies for asthma. Next slide, please. The question is, can big data, can mathematics provide solution? It is true that in the last few years, development of these high throughput technologies like omics offer a unique opportunity to unravel the complexity of the disease. However, it is very challenging to process, analyze, or interpret large volumes of data. And as a consequence of this, data-driven hypothesis-generating approaches are slowly overshadowing traditional approaches of carefully constructed questions and observations. And big data are being sold as panacea. They will solve everything. And people sort of use terms, AI, machine learning, deep learning systems, biology, as if per se they're going to provide solution. Next slide, please. However, all of these different methodologies are very powerful and different. Also, it is well worth saying that, for example, machine learning, which is considered to be really novel methodology, actually most concepts, statistical complex concepts used in machine learning, are drawn from multivariate statistics and are about a century old. Now, this requires a very specific and very special expertise, and the beauty of Imperial is it is indeed College of Science and Technology, and the underpinning mathematics, bioengineering, engineering is superb. Next slide, please. So we have recently sort of put together a review looking at using machine learning to understand this methodological shift towards data-driven analysis in SML research. And this gives you our idea of the overlap between artificial intelligence, machine learning, multivariate statistics that underpins it all. Next slide, please. And indeed, in the last 50 years, you can see that there are several phases, and we are currently in the expansion phase, where there's large increase in the number of articles published using these different methodologies. Next one, please. Indeed, UK is pitching well above its weight here, and as you can see, both in the realms of pediatric and adult allergy, researchers from Imperials are really sort of leading this globally. Next slide, please. I'm just going to give you a taster to give you an idea of what we can do using these powerful techniques to understand the heterogeneity of the disease. Next one. And it started by a simple question. You know, when we talk about these different features, food allergy, sensitization, asthma, we talk about them as if they are homogeneous entities, and yet they are very, very different, and each patient, each individual is quite unique. So we ask question whether the allergic sensitization is actually heterogeneous, because we know that different individuals have very, very different patterns of skin test and IgE responses that develop over time. To address this question, in one of the first research efforts trying to utilize machine learning, we used all of the data on all of the skin tests and all of the IgEs collected in a birth cohort well over a decade, more than 1,000 children, large number of data, then applying carefully constructed modeling together with our methodologist colleagues, and then running it to try to understand whether there are patterns underpinning these features that tell us more about the disease. Next slide, please. And fascinatingly, what this told us was that the feature that we call allergic sensitization really is heterogeneous, and that under this umbrella, there are at least 4 different types of sensitizations, only one of them being associated with asthma. But the strength of that association is remarkably, remarkably high. And not only that, this type of sensitization, comprising only a quarter of children with positive skin test or IgE, was also associated with severe disease. So now I can utilize data from thousands of individuals collected over 20 years to understand whether these individuals are different. But what can I do in a clinic? To address this question next, we utilize the newly developed microarrays which measure IgE in a component-resolved way, i.e. to individual allergenic molecules. So you get over 100 individual IgEs and ask the question, can we differentiate between benign sensitization that doesn't lead to the disease with pathologic sensitization, the one that is really important? And this work done by our methodologist, Sarah Fontanella in particular, has shown that among sensitized individuals, utilizing machine learning and network analysis, we can indeed predict with great degree of certainty which sensitized child will have asthma and which one will not. And next slide, please. Not only that, among sensitized individuals, both adults and children, within the context of UBioPred, Sarah has shown very elegantly that there are completely different networks of interactions that characterize mild asthma compared to severe asthma. So just by using multiplex chips, we can differentiate individuals who will have a disease or not, and also differentiate individuals with mild compared to severe disease. And this work is now extended with Paul and Bob into understanding the complexity and severity of food allergy. Next slide. Not only that, what we can do is then try really to disaggregate all of the diagnostic labels that we have. And I'm not gonna talk about this, Sejal is gonna address this, but I think this is a beautiful example demonstrating how unsatisfactory our current diagnostic labels are, in that preschool child wheeze really had very little sort of different types of wheezing, had very little relationship with underlying pathophysiology. Go next, please. And then application of modern mathematics on both data generated through wet lab and clinical research help disaggregation and understanding the disease, hopefully resulting in better stratification. Next one. So what we all know is now, what we have learned is that there is no single data source or methodology that can uncover complex mechanisms underpinning allergy in general, but asthma and food allergies in particular. Without understanding these mechanisms, we will not be able to improve outcomes. So what we need to do is urgently integrate all of these steps of research process, birth cohorts, with patient cohorts, with randomized controlled trials, with mechanistic studies in human tissues, but also in animal models, all underpinned by state-of-the-art analysis and also development of novel methodologies to analyze data that are fit for that particular purpose. So it is cross-disciplinary, cutting-edge analytics based on large, complex, integrated data sets that may provide answers to the biggest question that we have. So with that, I'll leave it over to Sejal to continue.
Great, thanks very much, Adnan. I always find it difficult to follow Adnan on a talk, but I'll do my best. It's great working with the team at Imperial. I can't tell you how good fun it is because, as Adnan has just explained, we've got so many different ways of approaching the research. It's really, really satisfying. So I'm just going to tell you a little bit about the approaches we're taking to understand a little bit more about childhood asthma, and especially severe childhood asthma. And I wanted to just alert you all to our new Centre for Paediatrics and Child Health at Imperial. Please have a look at the website. It'll give you a really good idea about the types of research going on as well. Next slide, please. So why are we interested in looking at asthma in children? Well, basically because it's really common. It's the commonest chronic non-communicable disease that affects children worldwide, not just in the UK, everywhere. But in the UK, over 1 million children are affected by asthma. And the group that we're particularly interested in are the group that have very severe disease. And that's because although they're a relatively small proportion of all children with asthma, they actually use more than half of all of our healthcare resources, and they're a really high risk group for asthma death. So this is the group that I'm going to focus on today. Next slide. And really, why is asthma an issue? Why is severe asthma an issue? So this is just to give you an idea of what goes on in the airways of children with asthma and how they present with this symptom called wheezing. So if you look at asthma is a disease of the airways, and if you look at the airway on the left of your picture, you can see it's nice and open and patent. Air flows in and out without any problems, and you don't hear any noises, no sounds, no difficulty breathing. But the one on the right is the airway of a child with severe asthma. And you can see there's hardly any room for this child to breathe in and out. The flow of the air is turbulent and they have significant wheezing. That's the key symptom that we see of children with asthma. Next slide. And how we can pick that up in the lab by doing lung function tests. This child is having a test called spirometry. And when he breathes out, he would have a significant obstruction of his airways. And the black line that you see here, the black solid line, is what his lung function would look like instead of the red dotted line, which would be a normal airway. So a significant difference and narrowing of the airways, resulting in the difficulties that these children get. Next slide. And the reason lung function is really important, it tells us about how well the lungs are functioning. But what we know by following children from birth up through now to adulthood is that children with asthma have a drop in their lung function by school age. So the blue squares here, you can see by the age of 7, already the function is lower than the other lines, and the orange circles and line are the children with severe asthma who have an even greater drop in their lung function by the age of 10, which carries on through to adulthood. There's no medicines that we have to reverse that reduction in lung function. So unless we do something early and treat these patients effectively early in childhood, this is a childhood onset disease, we've got horrible long-term consequences. So we really, really need to focus on severe asthma in childhood and improve its management. Next slide. So what goes on in these airways? I've shown you a sort of big overall picture, but what essentially happens is in a child who's susceptible to asthma, when they're exposed to essentially innocuous agents like allergens or cigarette smoke, pollution, or even a simple viral cold, an asthmatic will have two things going on, inflammation in their airways and a change in the structure of their airways, what we call remodeling. And the cells that are of particular interest that cause the inflammation are the ones I've highlighted here, the eosinophils. So that happens in asthma, but does it happen in childhood? Does it happen in childhood severe asthma? That's one of our key questions when we started out looking at these patients. Next slide. And to do this, what we did was make the most of a clinically indicated test called a bronchoscopy, which is where we put a fiber optic camera into the airways of these children to really, really understand what's going on that's driving their disease. Do they have eosinophils in their airways? And can we look at the airway wall to look for the structural changes and airway remodeling? And when we've done that, next slide, please, we see that children at about median age of 11 or 12 already have significantly increased eosinophils in their airways. You can see that on the graph on the left. And below that is the airway wall of this child. All the red dots are eosinophils in the child's airways. So marked eosinophilic inflammation already present in childhood severe asthma. And the other thing that really is striking in childhood severe asthma is the degree of allergy that these patients have, both to inhaled allergens and to food allergens. Lots and lots of allergy, lots and lots of eosinophils. Next slide, please. Why is that important? Well, the treatment that we use for asthma are inhaled steroids or steroids, and they're used to dampen down that eosinophilic inflammation and reduce the allergy, or the molecule that drives the allergy called IgE. The problem in severe asthma, though, is that these children have poor control despite having maximal doses of inhaled treatment. So they have what we call therapy-resistant asthma. Next slide. But we wanted to see whether it really is steroid-resistant asthma or not. So to do this, we undertook a study where we gave the children a high-dose injection of steroids to see, is it really steroid resistant or is it something else? But when we give a high-dose injection, actually the inflammation comes down, their symptoms improve and their asthma attacks improve. So it's not completely steroid resistant. The problem is they need such high doses that actually the side effects are unbearable. The side effects of steroids are horrendous, and we can't give the high doses that we would need to give to control their asthma. So we need something else. We need steroid-sparing treatments. And so what are those treatments? Next, please. One of the things we found when we'd given the children really high dose treatment was one of their molecules in their airways, the IL-5, interleukin 5, which is a molecule that attracts eosinophils into the airways, significantly reduced. And that's really, really helpful because we now have antibodies that can bind that IL-5 and stop it from coming into the lungs and stop the eosinophils from coming into the lungs. So the next question was, can we use this treatment that blocks IL-5 as a steroid-sparing agent for severe asthma? Having found all these research findings, we needed to translate it to patients. Next slide. And to translate, we're now undertaking a trial, a clinical trial, the first of its kind in the UK, where we've got 11 national centres who will recruit children with severe therapy-resistant asthma, and we will give them a treatment, to the anti-IL-5 treatment to reduce eosinophils, and compare it to a treatment that was already available that reduces IgE or allergies, and we'll do a head-to-head comparison to see which of those can treat these children with severe asthma. And like Adnan was saying, we don't want a one-size-fits-all. We know a one-size-fits-all isn't going to work. So one of the key aims of this trial is to see which of these treatments works best in which child, and which markers in the airways or the blood can be used to decide which is the best treatment for which child. And this is ongoing right now with Imperial as the lead centre. Next slide, please. So that's kind of a snapshot of some of the work we're doing with our older children, but another really important population, which I'm sure many of you will understand, are the nightmare of our preschool wheezers. What do we do with them? We're really, really struggling. And what's really worrying is that we're getting more and more data that children that have wheezing in early life, under the age of 5, are presenting in adulthood with chronic obstructive pulmonary disease. So that loss in lung function, which I showed you at about age 10, is probably happening even earlier, between the age of 1 and 5. And we've really got to be aggressive about stopping that, to stop all these patients coming to the adult clinics with obstructive pulmonary disease. Next slide. So, and the worrying thing, even in preschool years, is that the prevalence of wheezing in this age group is increasing in the UK. We're not doing very well at treating it at all. And if you look at the children that are admitted acutely with wheezing attacks, the ones that are by far and away the majority, 75% of all children admitted with wheezing attacks to hospitals in the UK are less than 5 years old. And that's unchanged for about 15 years. So we're really bad at treating this population. Next slide, please. So we thought, well, what's going on in the airways of these preschool children? Do they have the eosinophils? Do they have the structural changes? And when we've looked, we found that actually some of these patients by the age of 3 already have evidence of eosinophils in their airways and the changes in their remodeling. Next slide. And it seems that these remodeling changes occur with time, sometime between birth, and they're well established by school age. So we need to intervene in that preschool period to stop those permanent changes. Next slide. So what we've been doing wrong, as Adnan said, is we've just been lumping all our preschool wheezers together and saying, let's just try a treatment, surely it'll work. And what we've been doing is lumping them together and giving them all inhaled steroids without thinking, have they all got allergies? Have they all got eosinophils? And although we know that the children that have allergies and eosinophils respond to steroids, next slide, please. What we also know is that the majority of these preschool wheezers do not have allergies. And what we haven't had is any treatments for that large group that don't have allergies, that won't respond to inhaled steroids. And that's probably why we're not progressing in this age group. So we looked in the children that have had bronchoscopies, and actually we saw a significant proportion, more than half of the non-allergic ones had evidence of bacterial infection in their airways. And so the question was, would antibiotics be a potential novel way to treat preschool wheeze? Next slide. And so, as Adnan says, I got stuck there. I'm very much a bench scientist. And I was like, well, we've got these issues. We've got eosinophils, we've got allergies, we've got infection, we've got neutrophils. But how do we tease it all apart? And that's where Adnan and Sarah Fontanella were really, really helpful. And we undertook an unbiased cluster analysis of all of our patients and the characteristics of their airways. And what we found is that there were 4 groups, 4 clusters that we could see. One that definitely had allergies and lots of eosinophils in their blood. but a second really interesting cluster that definitely had bacterial infection and neutrophils. So whether I looked in my very hypothesis-driven way, or whether Adnan looked in his unbiased way without any hypothesis at all, we got the same answer. And that for us was really, really exciting. So what we're moving on to next is some stratified treatments for preschool wheeze, try and get a bit scientific in our approach rather than lumping them all together. And what we're hoping to do is to design trials that will split our preschool wheezers into those with allergies, to whom we'll give inhaled steroids, and those who have bacterial infection, who we would hope to give antibiotics to, and finally see, hopefully, a response that's targeted in these patients. Next slide. So I hope you've all understood that we have a really nice translational program of research at Imperial. We take clinical phenotyping very, very seriously. We take the science of the pathophysiology of the airways very seriously, and then we translate into clinical trials. And all of this with the help of all of our colleagues. So next slide. The last slide is just to acknowledge all of the colleagues and thank you all for your attention. Sorry, and I'll hand over to Lola now, who's looking at adults with asthma. Thanks.
Thanks, Sejal. So yeah, my name's Lola. I'm a clinical PhD student with an adult respiratory physician registrar by background. So I'm just going to talk to you briefly about severe asthma in adults and then build on that a little bit about what I'm doing for my research. Next slide, please. So this very much follows on from what Sejal's just been telling us, but we know that asthma has a number of different factors that predispose people to have it, and these can vary from allergens and viruses or infections to pollution and genetic predisposition. And people, and I specifically focus on adults, but who have asthma have this inflammation and remodeling that occurs in the airways, as you can see in the middle picture. And that really then results in this limitation of the airflow, which Sejal showed very nicely, where the air is unable to go through the airways, and it results in this obstruction that you can see on the picture on the right. And that obstruction critically doesn't occur all the time, but tends to, at least in the first instances, be transient, and it comes and it goes. Next slide, please. But if we look more specifically at severe asthma, these are defined by the European Respiratory Society as patients who need really high doses of these steroids. And this is high doses of steroids in an inhaler and or in tablet or injection form, and in combination with another agent, such as a long-acting beta agonist or a long-acting version of blue inhalers. And so patients who have this are seen as severe asthmatics. And it's estimated that only about 3.5% to 5% of asthmatic patients are severe asthma. Having said that, there's so many people have asthma that actually is around 200,000 people in the United Kingdom have severe asthma. And we know that these people have a really high healthcare cost. It costs about 3 times as much to treat a patient with severe asthma as a patient with non-severe asthma. And actually you also have lots of consequences on the mortality and the morbidity, people taking time off work and things like that. Next slide, please. But as Adnan said really nicely, it's not actually just, and Sejal, just one type of asthma. Although the diagnosis for severe asthma is very much, you just need to be on these treatments, we actually know that asthma is very heterogeneous, lots of different populations which overlap or might be quite separated, of which those patients have their asthma. And knowing these different populations really helps us as clinicians to identify the patients, but also to then work out what treatment they might respond, and then as scientists to actually try and think about how we might determine different features further and how we might develop treatments. So traditionally, we've very much always looked as clinicians as asthma being either child onset, adult onset, and then what type of pathway. So it's this allergic or type 2 pathway, which Sejal describes, where you get the eosinophilic asthma, and these are often childhood onset asthma patients. And then you also have this non-allergic or non-eosinophilic non-type 2 pathway, which have different causes and tend to be more infection related or pollution and smoke related. And trying to tear these apart gives us some information, but still we don't really know how to treat patients very effectively always. Next slide, please. So if we look at it in a bit more detail and think about these type 2 pathways, these are the patients who are sort of quite allergic, might have a large eosinophil numbers. And the the diagram shows the different treatment strategies we have for these. So when you get very severe asthma that's not responding to steroid therapy, we can start to think about what we call biologic therapy. And in this subset of patients, we've been able to show that if we can stop the eosinophils or stop the IgE, then actually we can make patients much better. We can really improve their symptoms and improve their quality of life. But what's very interesting, and what I'm focusing on with my research, is why actually not all these patients respond. So despite us saying, well, you have this type of asthma, how we define it, when we give them a drug such as mepolizumab to stop their IL-5 or omalizumab to stop their IgE, they still don't always respond. They don't always get better, even though we think they should. Next slide, please. So one of the reasons for this might be that actually we're thinking about it a bit too simplistically. We're just talking about eosinophils for treating asthma, but a bit like there's multiple types of T cells and different cells often have subtypes. There's been shown that eosinophils also have some subtypes. So this is work done by Mesnor and her colleagues, which showed first in a mouse model and then in humans that actually eosinophils can be very different. They can be different in their location, their shape, and their antigens and markers. And what she suggests is they've also got a different function. So they've got these lung resident eosinophils, which might actually be protective to the lungs, rather than the inflammatory eosinophils, which we associate with the problems and destruction we see in asthma. And so it might be that actually if we target all the eosinophils, we might not always be benefiting the patient. And I want to understand more how these different subtypes work and how that might influence treatment. Next slide, please. But another cell that I'm quite interested in is the neutrophil, which is also another white blood cell. And this can be seen in this type 2 or eosinophilic asthma, but also in the non-type 2 asthma. But we know it's associated with bad outcomes. So people who have poor lung function on high numbers of steroids tend to have higher neutrophils in their airways. And we're not quite sure why. As I say, it's associated with high steroid use, but that's a little bit chicken and egg, because you're on large numbers of steroids if you've got severe asthma. But likewise, we know that steroids can actually stop neutrophils dying, and therefore you might have higher numbers. It's also associated with infections, with smoke and pollution. There may be a genetic predisposition. But also, like eosinophils, we're not really sure of what their role what happens with them and what their function is. We tend to naturally associate neutrophils being there as maybe being destructive and bad. You see in other illnesses like sepsis, where you have infiltration of neutrophils, that it can cause a problem. But we actually also know that in some patients, differently located neutrophils can be associated with better outcomes. So are we being a bit too general in what we're looking at? Next slide, please. So I'm running, as part of my PhD, the PROGRAMS study, which is aiming to look at adults with severe asthma, looking over time and how their clinical and also their cells and immune responses change with those time. Next slide, please. So it's a bit of a busy slide, but it just shows the timeline of what we'll be doing with these patients. So we're going to recruit patients with severe asthma, and the idea is we do everything we might otherwise do in clinic, so that we're going to get the same clinical information that we can then take back once we have more scientific information to apply clinically, but then we get further information from an immunological point of view. So I'm going to be taking samples of blood, induced sputum, which is when we get them to cough up phlegm, and we can look at the different cells that we find in the airways from that. And then investigations, so the spirometry or lung function, which looks at how the air flows out of in and out of the lungs, as well as peak flow, which people do at home as well, and FeNO, which looks at the inflammation of the lungs. And the plan is to combine that with bronchoscopy information, where we can stick the flexible tube in, look at the cells as well as some tissue from the lungs, and to do this over 6 months. Next slide, please. But as well as the clinical information, we really want to see what's happening with those very detailed, with those cells, not just how many cells they are, but what their characteristics are, what type of subtype might they represent. So what I'm going to be doing is looking at something called aurora spectral flow cytometry. And this is sort of a step up from standard flow cytometry in that it enables us to look at lots and lots of different markers on the cells, even when we only have a few cells to look at. So with induced sputum, for example, you often don't get very many cells to examine, so we need to make the most of them. And what I'm able to do is look at how many cells there are, so how many neutrophils, how many eosinophils there are, but then to look in much more depth and see what different markers they are and how they might differ. And if that was to give us a clue as to whether they might be beneficial, harmful, how they might then influence that patient's outcome. And especially when I then combine it with the clinical information and the investigations. And the idea is to use aspects such as machine learning and this unbiased cluster analysis to see with all the different data how that differs with different patients, but also how that differs with different patients over time, when they might be having exacerbations, and also when they get started on different treatments, how the eosinophils, for example, might change. Next slide, please. So in summary, I think it's really important to remember how severe asthma is not just one disease. It's got lots and lots of different overlapping phenotypes and endotypes, these different populations. And we know that we know that this type 2 pathway of eosinophils and allergy definitely exists, and some patients respond really well to the biologic therapies, but not all patients do, and we're not sure exactly why. And likewise, we're not sure with neutrophils why some patients have those and what their role is. And I'm hoping that by looking with this aurora flow spectrometry in more depth, that we'll get a better understanding of how that immune system works in combination with clinical data, so we can look over time and relate that back to patients and then back into the clinical context. Next slide, please. And this is just to say thank you and just some acknowledgements from some of the great people in my lab. Thank you.
Thanks so much for the brilliant presentations. We're running a bit late, so I think we can have time for a quick question. And this is a question for Sejal. Someone asking about what's the potential role of MBA deficiency and IgA deficiency in preschool wheeze, and whether that has any sort of link with the role of bacterial infections.
Yeah, no, so we look quite closely at these children's immune systems before we, give any antibiotic treatment. And we haven't found any, certainly no association with MBL deficiency, and really nothing IgG or A tends to be normal. So there's something about their airways that's, specifically their airways, that's making them susceptible to these bacteria. Yeah.
Great, and I'm tempted to ask another question for a quick answer, Sejal, if that's okay. So sure. Someone is asking about whether there are any trials combining mepolizumab and benralizumab, and then a question about whether there are concerns about secondary immune conditions due to eosinophilic suppression with biologics.
So you just answered the first question with your second point, Martha. So we're very reluctant to use benralizumab in children because benralizumab wipes out all eosinophils. It's an IL-5 receptor antibody, which means all the eosinophils are reduced, even from the bone marrow, essentially, and from the circulation. And you're absolutely right. We need eosinophils. They're in our body for a reason. So I think we feel fairly comfortable with just anti-IL-5 antibody mepolizumab, but there's certainly no trials at the moment of benralizumab in the UK. They are being undertaken in the US, but I'd be very, very cautious about using benralizumab in children because they're still developing immunologically, and I'd be worried that we could be making them more susceptible to other horrible things. Yeah.
Great, thanks so much. I see Adnan nodding there. In the interest of time, we're going to move on. And I see Adnan has been replying to some of the questions in the chat, which is something we're going to be doing in the next week. We will come back with answers to the chat to any outstanding questions. So thanks so much to our asthma speakers. We're going to move on to the immunotherapy section. And we have Professor Steve Durham talking about the latest evidence and novel approaches to allergen-specific immunotherapy, and then Dr. Sanji talking about biomarkers and mechanisms of allergen immunotherapy, and you probably are familiar with them. You've seen them in conferences and things. I'm just going to do a little introduction. So Professor Steve Durham is a professor of allergy and respiratory medicine at Imperial, and he's also the head of the section for allergy and clinical immunology. He's been a key reference internationally in the field of allergen-specific immunotherapy, and he's led numerous translational studies of allergen-specific immunotherapy that have helped elucidate the mechanisms and inform novel treatment approaches, as well as a number of product registrations across the world. world. He's a member of the Immune Tolerance Network Steering Committee of the National Institutes of Health in the States, and he has had prominent roles in WOW and BSACI and EACI. And then Dr. Moore Samchi is a reader in immunology and allergy at Imperial. He's the lead of the immunomodulation and tolerance research group within the allergy and clinical immunology section at NHLI. He has key roles in national and international scientific societies as well, including being the chair currently of the scientific program committee of EACI. He's very heavily involved in both undergraduate and postgraduate teaching, including our masters, and he's joint editor-in-chief together with Bob Boyle of the journal Clinical Experimental Allergy. So I'm going to hand over to Steve for his talk. Thank you.
Yes, thank you. Thank you very much, Marta. And I'm privileged to be part of this symposium, and it's a great pleasure. I've learned so much so far. You get in your introduction, you referred to Leonard Noon, who was in Imperial and over 110 years ago did the first trial of immunotherapy, and this immunotherapy has been prominent within Imperial over the past 100 years, not least with Bill Franklin, who was the name, who's the clinic at St Mary's is named after him, and he did the first randomized controlled trial in 1954, and so that we have a tradition to lead up to stay up to in Imperial. Next slide. So allergen immunotherapy involves giving allergen extracts to which you're sensitive to IgE sensitized individuals in order to induce long-term clinical and immunological tolerance on allergen re-exposure. And this can be done nowadays in two ways. Firstly, by injection. We initially give weekly injections for 12 to 15 weeks, followed by monthly injections for 3 years. So this is not a treatment for the faint-hearted. Fortunately, there is a novel approach involving sublingual immunotherapy, whereby we give drops or a tablet under the tongue, which is an extract of, for example, grass pollen or house dust mite, and this is maintained under the tongue for a period of 2 minutes, and that's done daily. So the maintenance treatment is either monthly maintenance injections or daily tablets, which we normally recommend for a period of 3 years, and I'll explain why that is. Next slide. So we don't give this to everyone. This is just the algorithm for treating allergic rhinitis. You may say, well, is hay fever important? Well, the answer is yes, it is. It affects 1 in 4 in the UK. It has a major impact on work performance, school performance, and interferes with sleep and quality of life and leisure activities. The majority of patients, like as Sejal referred to with bronchial asthma, respond extremely well to antihistamines and to intranasal corticosteroids rather than inhaled corticosteroids. And if they respond well, it's usually, if they don't respond, it's usually because they're not taking it correctly. And if we discover that they are taking it correctly and they still get bad symptoms, and their dominant problem is a particular pollen such as tree or grass pollen, then we can offer them allergen immunotherapy. And this is the group that respond, those with moderate to severe hay fever who do not respond to a supervised trial of conventional anti-allergic drugs. Next slide. So to give you an example, this is just to give you a flavor. This is a lady who is busy. She's a management consultant, and she gives a typical history of what we call hay fever, seasonal allergic rhinitis. She doesn't get symptoms throughout the rest of the year. She doesn't have asthma. She has normal spirometry, so her lung function is normal, and that's important when we're contemplating this form of treatment. And in fact, out of season at the time when she was asymptomatic, her nasal mucosa on inspection looked normal. And she had a positive skin prick test, that's the SPT, to grass pollen. And on the basis of that typical history, sneezing, blocked runny nose during Wimbledon fortnight, that's when everybody gets grass pollen hay fever, then she had a very severe impaired quality of life. Next slide. And now it's really important, as I mentioned, to check good compliance with treatment. And this lady had actually got through 3 nasal sprays the previous year. So she'd certainly, during the pollen season, so she's certainly been taking a treatment. Next slide. And so she was given sublingual grass pollen tablet immunotherapy, which was started 6 months before the season. This contains pure grass pollen extract, 15 microgram of the major allergen in grass pollen, Phloem P5. Initially, she had bothersome side effects. She got itching and swelling under the tongue, but this settled within a couple of weeks. And during the summer, she only had very mild symptoms, and she virtually used no antihistamine treatment, and she was able to do the things that she enjoys, like gardening and cycling, which she'd been unable to do previously. Next slide. Next, please. Yes, and you know, this is not rocket science, but we do ask them how they are, and they comment as to how their hay fever's been compared to previous years, and you can see that she was a hell of a lot better. So that's the ideal patient: clear-cut seasonal disease, poor response to treatment, and no severe asthma, which may predispose to side effects. Mild, moderate, controlled asthma is okay. Next slide. So what we did initially 30 years ago, we did a study that showed that if you gave injection treatment for 3 years, you induced long-term disease remission for 3 years after stopping the treatment. And this is the same study now 10 years later, fast track to 2012. And what we see here is the weighted combined seasonal symptoms and rescue medication, that's on the vertical axis on the left, during 3 years on treatment during season 1, season 2 and season 3, and 2 years off treatment, having discontinued the treatment after 3 years. And what we see when we compare the light brown and the light blue panels, the light blue panels are those that had the tablet treatment over a period of 3 years. Then what we see is a marked reduction in symptoms of around 30 to 40%. And this is very consistent for these sublingual tablet immunotherapy trials, around a 30–40% reduction. So you may say, well, you know, what's that? They've still got 60% of the symptoms. It's not true at all. This is 30 to 40% over and above placebo. And 50% of these patients get better on placebo, because that's what placebo does when they're well looked after in a clinic circumstance. And also they get free access to usual anti-allergic drugs. So this is on top of the placebo effect and the anti-allergic drugs they receive. We're seeing a 30–40% reduction. So whereas 50% get better in the placebo group, 85% get better in the actively treated group, and that's because of this treatment. And the exciting thing here, if you look at the last two panels, is that as for the subcutaneous treatment, this treatment, next click, remains well. They remain well for 2 years after discontinuing the treatment. Next slide. So what we did recently, and published this in the journal JAMA a couple of years ago, this was a collaborative study with Mo Shamji and Guy Scadding and Moises Caldron, we asked the question, would 2 years be enough? And so we did what we call a double-blind, double-dummy, placebo-controlled trial, where the red people here had the injections and dummy tablets, the green people had the active tablets and dummy injections, and the blue poor souls had dummy tablets and dummy injections over a period of 2 years. And we monitored the response over the 2 years, then we stopped the treatment, and we asked the question, is 2 years enough for long-term tolerance, as 3 years was? So we're trying to shorten the interval. Next slide. Next slide. Now, our primary outcome was what we call nasal allergen provocation. We did monitor the patients during the pollen season, but we also blew grass pollen using this device on the left-hand side, and we monitored their symptom scores, and also we collected fluid from the lining of their nose, and Dr. Shamji will be talking about our mechanistic studies, and we also measured peak nasal inspiratory flow. Next slide. And the outcome is shown on this slide, essentially. If I can just remind you, SCIT, subcutaneous treatment is in red and sublingual treatment is in green. And you can see here, this is the reduction in peak nasal inspiratory flow after 1 hour and up to 10 hours after at this nasal provocation. And this is in year 1, year 2 and year 3. And what we see is that both forms of treatment are highly effective at reducing peak nasal inspiratory flow in response to antigen, and this persists out to 2 years, whereas we lose this effect at 3 years. And also, if we look at the patient's quality of life during the pollen season on the right-hand side, again, the blue are the double dummy patients. These are the placebo-treated patients. And you can see there's clear separation between them and the actively treated group. And this is a remarkable improvement in their rhinitis quality of life during the pollen season, corresponding to the, as I mentioned, the Wimbledon fortnight. This is May to July each year. And what we're seeing here is, again, during year 3, that the treatment effect is lost. Next slide. So you may say this was disappointing, but actually it's jolly helpful because it's informed international guidelines. Basically, 2 years treatment with both sublingual and subcutaneous treatment was highly effective and caused desensitization, but was insufficient to induce long-term benefits, which is what we refer to as tolerance. And so the message is you have to give the stuff for at least 3 years for it to have long-term benefits. Next slide. Next slide, please. So finally, not to be deterred, we're doing another trial, and this is going to be over the next 4 years, and this is a translational clinical project. It's a cooperative study. Dr. Shamji and I are working very closely together in a study where we're trying to understand the basic mechanisms of hay fever and the impact of immunotherapy. And what we're going to do here is take one of those molecules that Dr. Lowenthal was talking about, that's dupilumab, which we know to be highly effective in asthma, and we're going to give it in combination with 2 years sublingual grass pollen immunotherapy. And the reason for this is that we want to make the sublingual treatment more effective, have a shorter protocol, fewer side effects, and induce long-term tolerance after only 2 years of treatment. So this is Allergen plus dupilumab. Next slide. And this is just a little bit about dupilumab. This is the monoclonal antibody that targets the IL-4 receptor and downregulates the post-signaling events due to the cytokines IL-4 and IL-13. In particular, it blocks Th2 development and also IgE production. So that's a double whammy to try and combine with conventional immunotherapy. Next slide. So this is our hypothesis that the combination will induce, given for 2 years, unlike the slit alone, will induce long-term tolerance after 1 year off treatments. Next slide. The study design is very similar to the GRASS trial, which took place over a period of 5 years. This trial will be taking 5 years, and we've recruited our patients, and they're going into their first observation year during 2021. Then in this autumn, they will be randomized to either have the combination of sublingual treatment with dupilumab, with sublingual treatment alone, or they'll get the double dummy treatment. And we're going to be monitoring them up again with nasal challenge. And then after 2 years, we're going to stop the treatment. We're going to follow them up for a period of year 3. And then we're going to ask the question, was this treatment effective 1 year off treatment? In other words, can we induce long-term tolerance? And final slide. Excuse me, just to say this is the primary outcome, which is going to be nasal allergen provocation. Next slide. And just to say that this is the population that we've been targeting over the next 4 months. We have a wonderful clinical team working very closely with the lab team to recruit the patients with severe hay fever suitable for this trial. Next slide. And you can see this is how we've been doing. And this is during the COVID pandemic. You can see that when we started at the end of December until now, we're right up to our screening targets. We're aiming to screen 108 by the end of May, and we've achieved 110 by the end of May. And hopefully we'll accept a few more of these patients. But just to look how complex these trials are, in order to secure 110 patients motivated to undertake a trial like this, we had 3,700 hits on our website. And these all had to be pre-screened on telephone and then sorted into those who are suitable for screening. And you can see that the team have done jolly well over 4 months during a pandemic to recruit the right number of patients for the trial. And I hope, like Paul Turner, you'll invite me back in 5 years' time so I can tell you the results of the trial. Back to you, Marta. Thank you very much. And of course, to acknowledge my wonderful team, especially Mo for his cooperation in the lab. He now has his own independent immune tolerance group, and Guy Scanning and Moises Caldron, and those are our funders. Thank you.
Thanks so much. Over to Mo now.
Thank you, Steve, for this lovely overview, and thanks, Marta, for this introduction. Really, well, as you've tasked me to talk about mechanisms and biomarkers of allergen-specific immunotherapy, and really, what I would like to do is to give you a flavor of what we do here at Imperial in relation to understanding the underpinning mechanisms of how immunotherapy works and how we can really unravel the relevant biomarkers that will help us in terms of identifying responders and non-responders. Next slide. Right, without really going into much, as Steve has nicely alluded, that immunotherapy can be given either by the subcutaneous or the sublingual route. And really, when we are really trying to understand immunotherapy, one thing that really strikes out, if you give immunotherapy for 3 years, you can induce immunological tolerance. And what this means is you can stop giving treatment at year 3 and you see persistence of clinical benefits. So there is some form of immune tolerance that is being induced by allergen, in particular grass pollen here. And really, when we think about this, the understanding we have of the current mechanisms is that immune tolerance induced by grass pollen immunotherapy is associated with immune deviation. It is associated with induction of antibodies and induction of regulatory T cells. So clearly, we're targeting the adaptive immune response. And this is what we so far understand. And what I would really like to share with you is our current understanding of what happens at the innate immune response, what happens in terms of T cell responses, some novel subset of T cells, but also in terms of how can we use cluster analysis, machine learning analysis in terms of identifying biomarkers. Next slide. So firstly, I'd like to talk about how grass pollen immunotherapy, given either by subcutaneous or sublingual, how they are both able to generate a distinct subset of innate immune cells, and these have regulatory capacity, how immunotherapy is able to suppress effector T cells, in particular T follicular helper cells, and how we can really differentiate the antibody responses that are induced following subcutaneous immunotherapy and sublingual immunotherapy, and how that really shapes into, when we do some cluster analysis, into identifying responders and non-responders. Next slide. Next slide. So firstly, as I was mentioning about innate immune response and the cells of interest, in particular in relation to allergies, that are innate lymphoid cells. These are immune cells that belong to the lymphoid lineage that lack antigen-specific receptors. They have an important role in innate immune responses to infection microorganisms and in the regulation of homeostasis as well as inflammation. And the cells of interest that particularly we're interested in is the ILC2, the one right in the middle. And these cells promote, TH2 cytokines like IL-5, IL-13, and they really are driven by the epithelium mediators that are produced, the mediators that are produced by the epithelium, such as IL-25 and IL-33, as well as the TSLP. Now, the first evidence about these cells in allergic rhinitis was in 2015, next slide, where we hypothesized that natural allergen exposure is associated with induction of ILC2s. Now, what we did, we performed a cross-sectional study in and out of the pollen season, where we recruited untreated allergic rhinitic patients. So these are the SAR group, those who received subcutaneous immunotherapy, as well as non-atopic control. And on this graph, what you're seeing is just the disease burden. In season, you have an increase of the visual analog scale, which really leads to increased disease burden in allergic individual. This is somewhat suppressed in the SCID group, and we're not seeing much in the non-atopic controls. Next slide, next, and next, and next. And here what we did is we looked at the proportion of ILC2s that went up during the pollen season, the allergic individuals, and actually were suppressed or inhibited in those who were treated. And clearly what we were able to identify is a very interesting relationship, that those who were allergic and had received treatment or not treatment, particularly those who received treatment, had lower proportion of ILC2s and they had lower disease burden compared to the untreated group. And really, there were some elements of we were really interested in about what regulates these ILC2s in terms of production of cytokines. And clearly, we looked at IL-10 because we know that immunotherapy is associated with induction of suppressive cytokines. And when we stimulated ILC2s with IL-25 or 33, they were able to suppress IL-13 production in the presence of interleukin-10. And at this stage, we were very interested in understanding what really regulates these ILCs. So next slide. So what we did is we established a new method in the lab to be able to identify cells that are able to produce IL-10. These are IL-10 producing ILCs. And we spent quite considerable amount of time, and we're really interested in identifying the function of these cells and whether they're able to also inhibit the type 2 cytokine. So firstly, we established these cells in vitro in the lab, and we performed unbiased approach because we're using multi-parametric flow cytometry, and really we were able to home in the population of these ILC2s that are producing IL-10, and they had specific markers. These were particularly KLRG1 positive, and they were able to induce IL-10 as a suppressive cytokine in a time-dependent manner. Next slide. Next. And we really used the unbiased approach here to be able to look at, not just being very subjective and identifying these cells, but we were really being unbiased and try to identify the relevant population of ILCs that will produce IL-10 by doing unbiased machine learning analysis. And really, we're able to identify the cluster 6, metacluster 6 and 10 that were really flagging up that these cells were high in proportions, and they were very abundant in intensity of producing interleukin 10, which is an inhibitory cytokines. So really showing here the power of using mechanistic analysis with unbiased machine learning, and how we can really further have a look at these cells. So we're able to establish this population in vitro. And next slide. What we did actually is we performed a cross-sectional study where we recruited grass pollen allergic individuals. We looked at grass pollen immunotherapy treated patients who received subcutaneous immunotherapy, non-atopic controls, and we looked at the proportion of these innate immune cells, these ILC10s. And clearly, there was a dysregulation in the allergic individuals compared to non-atopics, and a restoration of this population in those receiving immunotherapy. And to our surprise, there was a relationship with these with the symptoms, with the rhinitis total symptom scores, with the proportion of these IL-10 producing cells. And we were able to reproduce that also with the disease burden parameters. Next slide. We further went on to validate these concepts into sublingual immunotherapy. This was a prospective control study of sublingual immunotherapy conducted with Stephen Durham. And really, we looked at the proportion of IL-10 producing ILCs over time, and really trying to see whether they also correlated with clinical efficacy. So next slide. Clearly, what we were able to do here is we looked at the proportion of these cells at baselines and at 12 months. This is looking at the panel on the left in the placebo-treated patients, but also those who received grass pollen sublingual immunotherapy. And really, we're able to demonstrate that there was an increase of this proportion of cells following sublingual immunotherapy, and they were persisted up to 24 months. And really, again, coming back, looking at the association with clinical response, this is perhaps one of the very striking biomarkers that to date we've able to establish that really correlates nicely with the total nasal symptom scores following intranasal allergen challenge. So the proportion of these cells are associated with the TNSS scores at the level of the cellular level, but also at the humoral level. Next slide. So what have we've been able to demonstrate that there is a proportion of these cells and they have regulatory capacity. They actually have very much they are somewhat dysregulated in allergic rhinitis and restored following immunotherapy, and they also have a very much regulatory responses, but also are able to restore epithelial barrier integrity as well and correlate with clinical efficacy. So what we're also doing here at Imperial, particularly, next slide, is to look at what really happens at the T cell level, and really, next slide, and how immunotherapy influences T follicular helper cells. Now, next slide. What's really critical is that when we talk about type 2 response, or particularly in allergy, we tend to focus on Th2 cells. But there are this particular subset of T follicular helper cells that interact with dendritic cells and also help B cells to produce antibodies. And these are actually, T follicular helper cells, and they produce cytokines like interleukin 21, but also they produce interleukin 4 as well. And the magnitude of this effect of a combination of interleukin 4 and IL-21 on B cells, next slide, really demonstrates the magnitude of total IgE that these cells are that B cells are able to produce in terms of receiving help from these cells. And we've spent time to really understand the mechanism of this. Next slide, where we recruited patients who received grass pollen subcutaneous or sublingual immunotherapy, as well as untreated grass pollen allergic individuals and non-atopic controls. And clearly immunotherapy is very effective, and you can see here when we look at rhinitis total symptom scores, these are reduced in skit and slit compared to the grass pollen allergics. And when we particularly look at the proportion of these IL-4 and IL-21 positive TFH, these are really increased. These are elevated in the allergic individuals compared to non-atopics, and actually really dampened and is inhibited in the skit and slit treated patients. So this really highlights the importance of how immunotherapy modulates T-cell responses. Next slide. And we've demonstrated the in vivo relevance of this by looking at IL-4, IL-21, and IL-6, these cytokines in the nasal mucosa over a time period following intranasal allergen challenge, looking at 0 to 8 hours. Clearly, we know that in line with previous studies, there is that IL-4 is induced during the late phase response, and there is an increase there. IL-21 and IL-6 is also elevated in the allergic individuals following intranasal grass pollen challenge. And immunotherapy, either given by skit and slit, really inhibits this induction of these pro-allergic cytokines, pro-inflammatory cytokines. Next slide. Without saying much, we looked at the epigenetic changes in this subset of population, and clearly what we've really been able to demonstrate is that these TFH cells, when we interrogate the cells in terms of the epigenetic output by ATAC-seq, really we see a lot of open accessible chromatin region highlighting the relevance and the capacity to be able to produce pro-inflammatory cytokines that may be very much mediate allergic response. And following skit and slit, there is an immune modulation that occurs, and really we see this less opening of the chromatin in the T follicular helper cells, but mostly in opening in the regulatory cells. So just finally, just few and the next. So and just to finalize, to conclude my presentation, and to really give you some of a flavor of what we've been doing in line with unraveling the differential responses in antibodies following in skit and slit, and how this may be relevant in terms of being a biomarker of immunotherapy. Next slide. This is a very elegant slide that Steve has already alluded to, a randomized double-blind placebo-controlled trial, skit, slit, and placebo. He mentioned about the efficacy, and I won't mention it, but apart from saying that both skit and slit were effective at year 1, year 2, we lost effect at year 3, and there was some other placebo effect. However, you looked at the clinical parameters. And the next slide. And what we've really done, we've really gone in and looked at the antibody responses systemically. So looking at in serum, we looked at IgG, IgA, we've looked at IgG4, we've looked at components to grass pollen, and also we had access to nasal fluid, as Steve mentioned, and we were able to do the same thing in a local as well as systemic environment. And we've been able to demonstrate that, particularly for subcutaneous immunotherapy, you get induction of IgG. So IgG is the predominant antibody that is induced, and for sublingual immunotherapy is IgA. And this is really important, and IgA is also induced in serum for sublingual immunotherapy. So a clear differential element there in terms of the mechanisms, and then how can we exploit that in terms of biomarkers of response. So next slide. And really, and this is next slide, and we've looked at various other parameters, and really what I'd like to showcase is the data on the right, where when we combine components for a specific IgE, IgG4, and IgA particularly, we're able to stratify patients not only according to groups as like skit, slit, or placebo, but also according to responder, no responder, and partial responder. And I think this is really the way forward when we can start looking at data like this and really think about how we can monitor our patients really well. Next slide. And I hope I've given you a flavor of the work that we're doing currently, which really combines, it combines basic science and making some discoveries really looking at preclinical studies and how we can take bench to bedside, but really encompassing that with collaboration in terms of data science with Adnan and really some really great clinical studies with Stephen Durham as well as Paul Turner. And just finally, last slide, just to thank really relevant members of the group who have contributed to this study and all the relevant collaborators. Thank you.
Thanks so much, Mo and Steve, for the brilliant presentations. Really interesting data. We're running a bit late, but it was really worth listening to every single word of your presentations. Just a very quick question and a quick answer, if that's okay, on a really interesting topic. Someone asking, what are the differences in terms of the effect in the immune system for immunotherapy to be able to induce long-term tolerance after 3 years, but not 2 years? So, yeah, Mo, would you like to address that?
Certainly, I think there are lots of elements here. I think there's the one need to think about the time course and the doses as well. So I think what we've learned certainly is that you need to give immunotherapy for 3 years, and 2 years is not sufficient. And clearly, at 2 years, we are on the road to tolerance. So we know that we can modulate T cells, we can modulate B cells, and particularly T cells at year 2, they're not fully converted into into where we would really want them to be, that they can be hyper-responsive. And certainly what we're seeing, although we know that we can then induce regulatory responses, we have antibody such as IgG4, but the key element here is that we just need that 3 years of treatment, and at 2 years for sure, in a T cell compartment, we tend to see this, the pro-inflammatory responses coming back, if not given for longer.
That's great. Steve, would you like to add anything to that?
Well, just very briefly, I think that T cells are necessary for induction of tolerance, and B cells are necessary for persistence of tolerance. And you saw that those T cell responses that Mohammed showed, they come bouncing back at 2 years, whereas we see persistence of the B cell response in terms of IgG or IgA antibodies for SCIT and SLIT. And I think it's not the actual immunoreactive antibodies, it's their level of either polyclonality or affinity maturation, whereby with prolonged exposure, more prolonged, 3 years rather than 2 years, you get a more highly effective avid antibody, whether it's increase in affinity or clonality, which is something we're looking at in collaboration with our colleagues in Denmark at the present time. So I think the short answer is that you need T cells for induction and B cells for persistence of tolerance. And that B cell persistence you see as a pediatrician, Marta, because when we originally develop our IgE responses in infancy and childhood, children tend not to get hay fever before the ages of 3 or 4 years, and that's because although they have IgE at an early stage, it has to go through affinity maturation in order to become effective in actually inducing the disease. And I would argue that you need 3 years of IgE to get effective IgE. You need 3 years of treatment in order to produce an effective Rolls-Royce IgG antibody that's going to block it.
That's great. Thanks so much for being asked to ask a question to Paul Turner about his talk earlier. And that's about how do you anticipate more research into biomarkers for severe reactions, or being able to identify people who truly at risk of severe reactions might impact on clinical practice, and are you expecting we clinicians are able to give more individualized advice to patients? So that's the question we're getting. Thanks.
Marta, I'm happy to answer that if you like.
Fine, that's fine, Bob. Yep.
Yeah. So I think with the severe food allergy, the hardest bit is working out what severe is and getting everyone to agree and finding people who've had severe reactions, because there's no test who tells you what reaction was a severe one, what wasn't, in any sort of reliable way, other than if someone dies, or they obviously had very severe food allergy, and so what Paul's doing is he's identified a cohort of people who very nearly died, who've been on needed invasive ventilation due to food anaphylaxis, and they have quite similar demographic characteristics to those who've died. So we think we're dealing with the same population of people who are unusually sensitive and have unusual difficulty in switching off their allergic reactions to food. So that's the first way. And then having identified and enrolled that population, which amounts to about 400 people in the NHS over the last 10 years, then a whole range of scientific approaches can be taken to understand what's different about them, from exome sequencing to gene expression to biopsy samples, and we'll be using a range of approaches to understand what's different about these people and try and work out a way of predicting and preventing those catastrophic reactions to foods.
Thanks so much, Bob. So it's been a brilliant afternoon with lots of interesting data and brilliant presentations. So I'm just very, very grateful to all our speakers for the great contribution today. Thanks to our attendees for being there. It's been a very popular meeting. I also wanted to say a big thank you to the IT and comms teams for helping set up this event. And I just wanted to say, if you're interested in research or education or both at Imperial in relation to allergy, you might want to follow NHLI on Twitter. You might see advertising for PhD opportunities coming up regularly. And then if you're interested in education, you might want to go on our website, where there is a full range of education opportunities, from 2-day short courses to a full MSc, and we have scholarships on offer for students coming in the next academic year. So feel free to go on the website and put together an email if you have any questions. So that's all from us today. Thanks so much for joining today. The event will be recorded and circulated to people who've registered, and looking forward to the next edition with new data from everyone. So thanks so much.